Hello, everybody. We are going to get started here in just another couple minutes. Thank you for joining, and we'll see you in just another 2 or so minutes.
There you go.
All right, well, let's get started. It is 10 a.m. our time. So I know some others will be logging in as well, but we're very excited to have Dr. Lonnie Nelson here. Again, we were lucky to have him with us last week. So we'll get that to you sometime during this event. But today we are talking about trauma-informed systems of care, how to see your setting through a survivor's eye. And so we want to start here. There are some notes on this slide that in case those answer some of your questions, but I'm Christina Clayton. I am one of the co-directors of the Northwest MHTTC. Welcome to our webinar. We want to first start with our land acknowledgement. And we are based in Seattle. And so we acknowledge the Coast Salish peoples of this land which touches the shared waters and of all tribes and bands within this area. And we mentioned the land acknowledgement, even though this is a virtual space, to really remember our history, remember the truth about our history, and work for justice in these communities. And we'll put a link in the chat if you want to know more about the stewards of your lands. We also are now having a labor acknowledgement and just want to address the unaddressed legacy of stolen labor and slavery in our society and country. This is often still an experience for many people in our communities. So we just want to acknowledge that as the University of Washington, we have benefited from that, as our country has as well. So a little bit about the Northwest MHTTC. Sorry about scrolling through the slides there. We are a nationwide network that is supported by the Substance Abuse Mental Health Services Administration, or SAMHSA, and our network is in its 5th year. We have 10 regional centers, a National Indian Alaska Native Center, and a National Hispanic and Latino Center, and a network coordinating office. So this same structure actually applies and has been around for another 25 years in the addiction field, and also newly in the prevention field, about as long as we have been going. So all of our events are free, all are pretty cross-cutting topics, so you can get to some of those. We'll put a link in the chat later. A little bit about our Northwest MHTTC. We are sited in the University of Washington in the Department of Psychiatry and Behavioral Sciences. And our goals are the same as the network: to support mental health related best practices and EBPs. We want to heighten awareness, knowledge, and skills, foster alliances to our diverse communities and their training needs, and most importantly, share free publicly available training and TA. Our area of focus for the network is EBPs for psychosis, but we train on a lot of different topics and are always striving for equity, diversity, and inclusion topics, culturally responsive and relevant and driven practices, as well as provider well-being. And how we do that, like today, webinars, we have virtual learning communities for our Region 10, we have online courses anyone can take, resource library, and a podcast. And Dr. Nelson and I just recorded another episode, so those will be up shortly on our website. Some housekeeping. We are doing something a little bit different today. And so you might notice that there are a number of panelists, including myself and our team. I want to give a shout out to Gabrielle Orsi, who is our program manager, and she's in the background, as well as our project coordinator, Jess Angel. And so they're here. The three of us will be happy to try and answer any questions in the chat. And, you know, if you're a webinar participant, you're not able to be on camera. Normally it's muted, camera off. We are recording, there's closed captioning. This video will be available later along with the slides, and you can do a certificate of attendance later. You'll get an email about that. But for general folks, please go ahead and put just general chat into the chat box. If you have something for our team, you can message just us directly, our hosts and panelists. If you have a content question, though, Dr. Nelson will be answering some of these through the presentation. We'll be stopping at a point or two, as well as the end. So go ahead and put your question at any time into the Q&A box. But today, what's different is we asked at registration if anybody might want to be unmuted and on camera. And so for people who already registered as panelists, you might be here with your camera on or not on. It's up to you. We are asking, you know, that you don't unmute and talk just at any point, but when Dr. Nelson has said, okay, now I'm ready to take some questions or discussion. And so what we're asking for people that already registered, you have the power, you know, to unmute and come on camera when we do that. So please raise your hand if you have a question, and we'll make sure to get to you in that way when there's that time. And as far as the Q&A, panelists may have access to be able to respond. So we're asking that just our team will manage the questions in the Q&A to make sure we can try to get to as many things. You're welcome to put any questions into the Q&A, panelists or otherwise, at any time. All right, so I think that is that. We also like to share in our events that we always want to have a, you know, person first and inclusive sort of way of discussing and talking about this, as our network has, you know, supported putting this slide in all of our events, because we want to utilize affirmative, you know, respectful and recovery oriented language in our events. We know there's a lot of diverse perspectives. So we thank you for your participation in that. Lastly, we have a short evaluation survey at the very end of the webinar. We'll be putting the link in there early in case you have to leave. You'll get an email as well, but it takes just like 2 minutes to do. It's confidential. We don't know who said what, but we look at all of your feedback. So we really appreciate your input. If when you're asked for a personal code, it asks for quite a lengthy set of numbers and letters. Pick whatever you want. This is a one-time event. Just do whatever works for you. We mostly just want your feedback. Well, that's exclusively what we want, honestly. And then SAMHSA, you know, does support our work, but they don't have any particular opinion or input on this exact content. So that's our disclaimer. Now to the good stuff. Okay, so hopefully, just looking, hopefully there's no other big questions from logistics point of view. We are very excited to have Dr. Lonnie Nelson here again today. Excuse me. He is a descendant of the Eastern Band of Cherokee Indians and earned his PhD in clinical psychology from the University of Arizona and completed a postdoctoral fellowship in rehabilitation psychology at University of Washington's Harborview Medical Center here in Seattle. In 2012, he returned to the field of Native health disparities through the Patient-Centered Outcomes Research Center Development Award K-12 at the University of Washington School of Public Health. Dr. Nelson joined the Washington State University College of Nursing in 2015. Lonnie, I think that you actually may want to be doing your own introductions, and I apologize. I was just going through your usual things, so please pop on camera if you want me to stop. Just realized about halfway through, I'm like, I think you wanted to introduce yourself. Is that still true? Because we can just stop there.
Yeah, no worries.
Okay.
Do have a
All right. Well, I will turn it over to you because you can speak on you a lot better. Thank you so much for being here again today. Thank you, everybody, for being here as well. And I'll turn it over. Thank you so much.
Good morning, hostess Unali. Well, as Christina said, my name is Lonnie Nelson. I'm a clinical psychologist by training and a descendant of the Eastern Band of Cherokees, AniKituwah. And I'm associate professor in the Washington State University College of Nursing and chair-elect of the Department of Nursing and Systems Science, which will be effective on July 1st. A little bit about me. As I said, my ancestors come from the Eastern Band of Cherokee Indians. And for those of you who don't know the history, when the Trail of Tears relocation of the Cherokee people from the southeastern United States to Oklahoma occurred, there was a relatively small population who remained behind, engaged in various legal and military battles to keep their land and stay where they believed that they belonged. And those are my relatives. I did complete my bachelor's, master's, and PhD all at the University of Arizona. I grew up as the child of an Indian Health Service nurse. So I lived on several reservations and ended up graduating from high school from Tuba City High, if there's anybody in Arizona who's familiar with that place. I currently work with an organization called Partnerships for Native Health. And our mission is to reduce and ideally eliminate the health disparities that are experienced by Native peoples of this continent in virtually any domain in which they exist. And the reason that I do what I do is so that cute little munchkin there with the rainbow face, my daughter Amelia, doesn't have to experience the same kind of health disparities that my dad there and his mom there experienced. And so my current work consists of a range of projects. I primarily conduct research on culturally adapted evidence-based interventions for various conditions. Everything from suicide prevention to enhancing retention in opioid use disorder medication-assisted treatment programs, to looking at cognitive health with advancing age in our urban Native elder population. So a pretty wide range of activities in my research work. And in the end, just kind of hoping to make a difference. As Christina mentioned, I did do my postdoctoral fellowship at Harborview Medical Center here in Seattle, which is the level 1 trauma center for the WAMI region. That's Washington, Alaska, Montana, Idaho, Hawaii. So for a year, I carried the pager that all of the nurses' stations had the number 2, and they called me in case or in the event that somebody on their unit was having a hard time with what had happened to bring them to a level 1 trauma center. And during that year, I got about 18 calls a day, and generally tried to help people handle the situations that they were facing. This all came from my interest in neurorehabilitation, which is, of course, rebuilding nervous systems that have sustained some kind of damage. And so oftentimes that happens through some sort of traumatic event. And so I kind of became an expert on trauma and trauma-informed systems by accident. But nonetheless, I'm happy to share my experience with y'all. So today's session, I'm going to talk a bit about types of trauma to start off with, just so that we're all talking about the same things. I'll talk a bit about how trauma gets transmitted across generations, and then a bit about triggers, responses, and behaviors. and then on to trauma-informed systems, environments, and interactions. And then at the end, I thought it would be good for us to engage as a group, as a community, in a brainstorming exercise where I'll provide a fact set about a particular individual and their situation. And then we can talk about, what different points of the system of care that individual will encounter and what should and should not happen at each one of those touch points along the way. And then we'll end with a discussion. So to start off, trauma. We all know what trauma is, right? So there's physical, psychological, and cultural traumas, and we often refer to those as direct traumas, and that meaning that the person that you're interacting with is the person who experienced those direct events.
Anything is not working well.
There's also vicarious or secondary trauma, and that occurs in people that have intimate or empathic interactions with folks who have experienced direct trauma. We'll talk about the different ways that that can happen and what that can look like. And then intergenerational trauma and how that gets transmitted down through parental relationships. So primary trauma. Physical trauma is a sudden physical injury. This can be blunt force or penetrating. Interestingly, I also spent 5 years working for the Defense and Veterans Brain Injury Center, 4 of those years at the Rapid Power Projection platform of Fort Carson Army Base in Colorado Springs. And so I saw various manifestations of sudden physical injuries, as one might imagine, among the soldiers returning from theater of operations. Then there's psychological trauma, damage or injury to the psyche after living through an extremely frightening or distressing event. This often accompanies physical traumas, as one might imagine. If you have experienced a sudden physical injury, there probably is a psychological and emotional component that goes along with that, and is considered a related but separate form of trauma. Then there's cultural trauma. And this is an overwhelming, often ongoing physical or psychological assault by an oppressive dominant group on another group's cultural resources through force, threats of force, or oppressive policies. That's the definition by Subica and Link in a great article that they wrote, published in 2022, looking at cultural trauma as a root cause of health disparities in marginalized groups. And cultural trauma really affects indigenous, immigrant, and marginalized populations across the globe, right? It's not a phenomenon that's limited to any one particular group, and certainly has affected multiple subgroups within the American population, and continues to affect those subpopulations. So then there's secondary trauma, which is sometimes called vicarious trauma. And this is a process of change resulting from empathic engagement with trauma survivors. So anyone who engages empathically with survivors of traumatic incidents and material relating to those traumatic events is potentially affected. And this includes, of course, health professionals. I'm sure that many of you here today have had some experience with vicarious trauma. Some signs of vicarious trauma that you can see in folks that have close contact with these folks is sleep disturbances. They may have nightmares about the traumatic events that their clients or relatives have experienced. They may experience appetite changes, either increase or decrease. They may experience hypervigilance, just having been interacting with someone to whom something traumatic has occurred may increase their awareness that those kinds of things can happen, and they can happen to anybody at pretty much any time, which can lead to this feeling of always being on edge, which is then, of course, related to an exaggerated startle response. And you may see negative coping strategies employed in these folks: smoking, drinking, acting out. Emotionally, they may experience feelings of helplessness or powerlessness, just as a result of having heard and been exposed to so many of these stories and just not feeling like they can do anything to prevent these events from happening to people. Helpers may experience survivor guilt, right? So why did this have to happen to this person and not to me? Why am I so lucky? They may experience emotional numbness. This is often thought of as a cardinal sign of burnout. They may also have oversensitivity to certain topics that are related to some of the traumatic material to which they've been exposed. They may have some degree of emotional unpredictability. They may react to things that seemingly don't have the kind of salience that one might think would cause the kind of emotional reaction that they exhibit. And they may have a general sense of fear and anxiety. A case study in vicarious trauma. Full disclosure, this was me on my postdoctoral fellowship. Native male, 30 years old, all coursework for PhD in clinical neuropsychology completed. Someone who experienced an outpatient rehabilitation for traumatic brain injury, spinal cord injury, polytrauma, toxic exposures, so on and so forth. And then the exposure to inpatient, acute, and post-acute rehabilitation hospital rotation. Multiple 12+ intake assessments per day, including cognitive evaluations, pain management assessments, recent spinal cord injury stabilizations, fresh polytrauma cases. The spinal cord injury cases were particularly challenging in that at that point in the injury, it's often unclear how much function they may recover and how much may be permanent damage and loss of function. And so, Symptom presentation, started having nightmares, panic attacks, increased alcohol use. I was first diagnosed with hypertension during that year, and multiple relationship issues that came about, just not being able to really connect with folks. The timeline, symptom onset was within a month. They worsened over a 6-month period and then began to decline spontaneously. Stable effects that remained for years into the future was the increased alcohol use, sleep problems, and the sense of being emotionally unavailable. So firsthand experience of what it can be like. Intergenerational trauma. Now, you can think of intergenerational trauma in a few different ways, but the most direct and I think easy to comprehend way is as a special type of vicarious trauma. So as a defined vicarious trauma, a process of change resulting from empathic engagement with trauma survivors, affecting anyone who engages empathically with survivors of traumatic incidents, material relating to their trauma is potentially affected, including the children of those survivors, as one might imagine. There's often a debate over how quote unquote real intergenerational trauma is, but I think that those folks don't really take the time to consider that these folks who have had these traumatic experiences are then rearing children, right? And there's a lot that leads through that parental relationship. So there are some biological pathways that have been identified. DNA and gene expression changes in offspring have been seen. We know that there's in utero exposure to stress hormones. If a mother experiences a traumatic event while pregnant. But then there are also, the laying down of the neural pathways in a child that leads to them having an endogenous exaggerated startle response, right? Even though that's a conditioned response, it is in fact neurologically, rooted. And there's also learned hyperarousal. That's the adaptive response to always be on alert, on edge. Behaviorally and emotionally, they experience, the offspring of these individuals may experience cumulative emotional wounding, right? So all of the emotions that are associated with the trauma that their parents experienced, may be directly bestowed upon them, experienced by them in a cumulative manner. there's the family stories that surround the trauma history, right? And those family narratives can condition a person or prepare them in a way that evokes trauma responses. Normalization of hatred, cruelty, and dehumanization toward others, specifically of a particular group. Anytime that you have one group of individuals in conflict with another group of individuals, there's going to be, unfortunately, some degree of that conflict that is passed on in the form of normalized attitudinal positions with regard to the outgroup, that other group. Parents bypassing or not coping with their own trauma and having trauma responses freely in the environment that the child is being reared in. And this can take the form of aggressions and microaggressions, some of which may be so slight that they're not even consciously registered by the offspring, but nonetheless affect the way that they develop and think and feel. So even in the absence of explicit adverse childhood experiences, or ACEs, marginalized populations have rampant intergenerational trauma. But on top of that, everything I just talked about, they then also experience the effects of these adverse childhood experiences, right? And those are also more common in marginalized communities. And when I say marginalized communities, I mean any marginalized community, not necessarily racially defined, but also socioeconomically defined, geographically defined. There are just certain groups that are more persecuted than other groups. And that persecution often leads to adverse childhood experiences in their offspring. So when we talk about triggers and trauma responses, triggers can literally be anything that reminds one of the traumas that they have faced. There's the obvious, the sights and sounds of situations that are directly reminiscent of the traumatic events. But they can also be social situations where power differentials are present, right? It can be just any situation where an individual doesn't have equal footing with other people in the situation. That can be a triggering event. They can also be reminders of what was lost in that traumatic experience. Trauma responses can vary dramatically and widely. They're generally a response that help the person survive or cope with the trauma at the time, but that is no longer really functionally useful in their environment. Can look like aggressive behavior or anger outbursts, dissociation or spacing out, any form of escapism, including alcohol, substance use, but also binge watching, television shows, anything to get them away from their present reality. Can also look like disdainful attitude and microaggressions toward others of a group associated with the traumatic experience. It may also just look like vindictiveness, right? And it can manifest that way with lateral violence and those kinds of behaviors as well. So a pretty wide range of trauma responses. In terms of what they can look like in interpersonal interactions, the person may experience a craving for control because they were made to feel so out of control in the traumatic experience. Agreeing to things just to keep the peace in a relationship. Feeling on guard all the time. We mentioned that with the hyperarousal. But that can also manifest in interpersonal relationships, right? That emotional unavailability that I was talking about. If you're on guard all the time and you have difficulty trusting, then you have difficulty being vulnerable, and that can interfere with relationships. Having a negative worldview, dwindling trust for other people, seeking constant escapism. So again, most of the trauma responses that people experience don't happen in isolation, right? They occur in the context of interpersonal relationships. And that's important to keep in mind, that the interactions are where these things come out and where they are most plainly seen. Okay, I scheduled in a pause to take questions and have a brief discussion of the different types of trauma, transmission of trauma across generations, and everything we've talked about up to this point. So what thoughts do folks have?
Again, a reminder, if you are in the panelist list, you can unmute and come on camera if you haven't already. If you have a question for Dr. Nelson, we don't have any in the Q&A at this moment, but I'm sure someone might be thinking about it. So anyone have a question?
Yeah, I think that probably the material up to this point is review for most folks.
Oh, we got one.
What takes place when vicarious trauma leaves untreated? So you will get various trauma responses. And it's going to differ based on the person and how it manifests for them individually. And also the type of vicarious trauma. So if you have a person who, say, is a sexual violence helping professional that on a day-to-day, interacts with people who have experienced rape or some form of sexual abuse, for that person, it may manifest more clearly in their interpersonal relationships, in their romantic relationships, right? Having been exposed to so many traumatic stories from the people that they try to help on a daily basis, that may bleed into their own personal narratives about, what romantic relationships are like and what the inherent dangers are. Whereas if you have someone who perhaps is a police officer, that may manifest in, more something that looks more like classic PTSD with hypervigilance and flashbacks and things like this. So it's pretty highly individualized what it can look like untreated, or even treated for that matter. Yeah. If
Okay. Oh yeah, go ahead.
Yeah, if clients are vindictive towards staff, is there a place for accountability or stating that this behavior is unacceptable? We completely understand its roots in trauma, but are staff expected to just take it always? Yeah, I talked about this, or a related topic to this, in last week's presentation, in that while it may not be the person's fault that they're behaving the way that they're behaving, it is still their responsibility, right? They still have to be responsible for their behavior. It's not as though you can just say, well, that person, has a history of trauma, so they can do whatever they please, right? That's certainly not the case. But there is a distinction between fault and responsibility. And I think that having the perspective of understanding the behavior is rooted in trauma can help us to be more productive in the way that we help folks to own up to their responsibility for their behavior, if that helps.
Thank you. I know we did have one question in the chat that we'll try to get here. It says, how are you able to identify what might be generational versus direct or vicarious if the individual cannot recognize it or doesn't recognize it as generational? Yeah,
so that's, intergenerational trauma from my perspective is vicarious trauma. So it's rooted in the narratives, the stories, the interactions that they've had with their family members. And I'm not entirely sure that a person would necessarily have to recognize that their traumatic responses or their trauma responses are coming from an intergenerational source, so long as they can identify the trigger that's being triggered and understand the automaticity of their response to that trigger. If that helps, that's, the first step is recognizing the the trigger and how they are coping with it. And then once that's recognized, whether they acknowledge that it's intergenerationally rooted or not, you can begin to talk about it as a conscious decision going forward, because it's been identified, it's been labeled, it's now a thing that can be referred to and talked about.
Great. Any last call? Oh, wait, here's another one. Oh, yeah, I was going to say the same thing. I really appreciate sharing your own personal experience. I know that hasn't always been the way in our fields. And yeah, so I appreciate that as well.
Yeah.
Any last, oh, go ahead.
I thought that, why not be the person who, makes it personal, right? I mean, so many of us have these experiences because we chose to be in the helping professions, right? It's not, we shouldn't be thinking about it as something that only other people experience, right? It should be very personal to most of us, I think.
Yeah, and just for folks who might later listen to our podcast discussion, that was sort of another piece of this becoming trauma informed, is just really thinking about what have we all been through? What is it like for any of us to seek help, and what that experience is like is so greatly shaped with, how we are received or treated or mistreated. Another question in the chat: how deep do you think intergenerational trauma goes?
I would say all the way to the roots of one's self-conceptualization. Who you think of yourself as a person in the world. If you try to answer the question, well, what kind of person am I? You can probably find intergenerational trauma all over that answer, right? Because the stories that we tell ourselves about who we are come from how we were reared. And they come from the stories that we are told about our relatives and about our ancestry and about our roots. I mean, it's one of the reasons that I make it a point to identify as a descendant of the Eastern Band of Cherokee Indians. For people who know the history, that says something about my self-conceptualization. I am inherently a bit stubborn. and I like to think that comes from there. But that's also a trauma narrative, right? That's an acknowledgement that a good number of my relatives were shepherded across a 1,200-mile forced march to occupy a territory that they didn't know how to necessarily survive and thrive within, because the ecology was so totally different than it was at the Smoky Mountains where they were moved from. And so I think that it goes all the way down to the roots of who we think of ourselves as people.
Right. Well, last call. If anyone on the panelist side wants to raise their hand or unmute and ask a question, but thank you for everyone's patience. My power went out at some point during our, so apologies. I had to log off and log back on, and we're trying this new unmute and have people be able to discuss. So with that, maybe we'll just turn it back to you, and we'll pause again when you're ready for more discussion.
Okay, sounds good. So, how do we minimize the effects of trauma on our interactions? Because, to be honest, that's the best we can really probably hope for, is to minimize the effects. I don't think that we can ever truly remove the effects entirely, but we can try to ameliorate the effects of trauma on our interactions. And it can and should happen at multiple levels. I'm sure a lot of folks are familiar with the Raffenbrenner, social ecological model, where you start with the big picture and thinking about public policy, laws and policies and so on and so forth, regulations, and then you think about community level factors, how our community is designed, connected? What are spaces populated by, and who are spaces populated by? And then you come down to maybe the characteristics of the specific organization within which you function. So you can think about your clinic, maybe that you work with, or maybe the schools that you interact with, or various workplaces where we all do our jobs. And then you think about interpersonal dynamics, family, friends, social networks, and how those interactions may or may not be affected by traumatic experiences or histories. And then think about the factors within an individual, your own knowledge, attitudes, skills, beliefs. How is your history or a given person's history of trauma affecting the narratives that one tells oneself about everyday interactions that they're engaged in? As psychologists, we often talk about depressogenic thinking and attribution errors. And, if somebody is nasty to us, we assume that it's something about us, right? Because we first tend to interpret events based on, our presence in a situation. Whereas it really could just be the fact that they're having a terrible day and you got in the middle of it and have nothing to do with it, right? But if you have a history of being blamed and shamed in other, relationships, significant relationships, thinking parents and siblings, so on and so forth at this point, that may be your go-to interpretation of the situation, right? And so, things can be related to or impacted by traumatic history at all of these levels. And certainly it is probably beneficial to at least think about how each one of these levels may interact with a traumatic history, not only in ourselves, but also, of course, in our clients and relatives. So that leads us to now go into the topic of trauma-informed systems. And a loose, easy definition is a system that's designed to avoid triggering trauma responses. That's basically it. That's the whole thing right there. A trauma-informed system just really tries to think about avoiding triggering trauma responses in the people that interact with that system. So some key ingredients for creating a trauma-informed system. If you're in a leadership position, leading and talking about the transformation process of going from status quo to becoming trauma-informed. And that is going to be a transformation process for most organizations because it's a relatively recent development, I would say, in organizational culture to think about trauma-informed care and what that means and the importance of being trauma-informed. And this transformation process will include engaging community in organizational planning and bringing in members of the community from outside the organization and saying, hey, we would love for you to tell us how we can better serve you, how we can, take potential triggering situations out of the equation for people who interact with our system. And oftentimes that information can't come from inside the organization. That oftentimes has to come from engaging community and getting outside perspectives. Providing training to clinical as well as non-clinical staff members in trauma-informed care is critical. Anybody who interacts with the client base for your organization should have some fundamental training in trauma-informed care. Whether they are in the billing department or reception or community outreach, not just the clinicians, right? This needs to be everybody. Fundamentally, you want to create a safe environment. You want to also try to prevent secondary traumatic stress in your staff members, right? Have some protective measures in place, have resources available that are completely non-stigmatizing. Allow for and encourage the use of mental health days for your staff to take the time to handle what they need to handle for themselves. And to the extent that you can, hire a trauma-informed workforce. Oh, thank you for all the thumbs up and the hearts and the claps. I love that they included that feature on Zoom. But these are really key ingredients for creating a trauma-informed system, right? These are the things that need to be taken into account. You want to shift the system from asking what's wrong with you to what happened to you. So realizing the widespread impact of trauma and understanding potential paths for recovery is key, and recognizing the signs and symptoms of trauma in individuals, families, and staff, right? This is just a fundamental shift from, well, in how the organization approaches an individual who's seeking care, right? It's not what's the problem with you, right? It's what's the problem with the course of events that led you here, right? It's what happened to you, not what's wrong with you. So integrating knowledge about trauma into policies, procedures, and practices is key. You want to actively resist re-traumatization. So you want to avoid creating an environment that inadvertently reminds patients of their traumatic experiences and causes them to experience emotional and biological stress. So if you consider what it's like to walk into most clinical settings, there's harsh fluorescent lighting, there are, maybe loud waiting rooms or crowded waiting rooms. There may be other folks that are struggling, in the reception area. Even the furniture that's present in a reception area can have a potentially re-traumatizing effect if it's, overly sterile or got a question in the Q&A. When it comes to different types of trauma, such as intergenerational and cultural, I definitely see the patient have the symptoms and other criteria that points toward a PTSD diagnosis, but have difficulty matching these types of events to criterion A. Is there a more appropriate diagnosis? As far as diagnosis, PTSD, as you point out, criterion A requires an event, right? A thing that happens that you can point to that was a traumatic experience. The only thing I can think of might be something more along the lines of the psychosocial history of the person. So I'm thinking what used to be like axis 4 characteristics of the social and psychological environment of the individual. That's probably the direction I would go, like the V codes, to use old-timey speak. Thanks for the question. So when we consider the physical characteristics, like I started to ramble on about, you want to be sure that the parking lots, common areas, bathrooms, entrances, and exits are well lit, but not necessarily harshly lit, but people need to be able to see everything that's going on. Ensuring that people are not allowed to smoke, loiter, or congregate outside entrances, that can be intimidating for somebody with a history of trauma. Monitoring who is coming in and out of the building, but doing so in an unobtrusive manner. You don't necessarily want to have a sign-in sheet that everybody has to sign in on at the time that they arrived and their full name, right? That other people that come after them will then see who's on the sign-in sheet. But you do want to have a sense of who's coming and going, right? So you want to try and do that as unobtrusively as you can. You want to position friendly security personnel inside and outside the building. So you don't want somebody who looks like a SWAT team member, strolling around outside or inside the building. But having someone whose function is clearly to keep the space safe is helpful. But that person shouldn't be garbed like a military operator of some kind. So keeping that in mind, and keeping noise levels in waiting rooms low is important. Using welcoming language on all signage is helpful. Making sure people have clear access to the door and can easily leave if they feel the need to, right? You don't want barriers between them and the exit. You also want to consider the social and emotional characteristics of the environment. You want to make sure that there's somebody there to welcome people and ensure that they feel respected and supported. Ensure that the staff maintain healthy interpersonal boundaries and can manage conflict, and can be responsive to a person who may be in a less than perfectly stable emotional state. You want to keep consistent schedules and procedures. You don't want people to face an unpredictable situation when they encounter your organization. Especially if they've had previous contact, you want to try and be sure that things look and feel as they're expected to look and feel when people encounter your organization. When changes are necessary, you want to make sure that you give sufficient notice in advance of changes, especially if there are changes that are going to happen with regard to policies and procedures that people are going to have to interact with or be subject to. You want your communication with your client base to be consistent, open, respectful, and compassionate. Again, from all staff members, including that jerk in the billing department who's always mean to people, right? Well, we got something else in the Q&A. It's not so much a question, but a comment as to the importance of communication after an incident to check in to see the staff is safe, etc. Yeah, absolutely. That is key. You want to make sure that if events have occurred that may have been triggering for staff or anyone in the organization, you want to make sure that after the crisis has been resolved, checking in with folks and seeing what kind of responses that they're having to the situation, making sure that as I mentioned, I think in the podcast portion of talking with Christina, normalizing people's responses to traumatic events is really important. When a person's experiencing acute stress disorder or symptoms thereof, in the immediate aftermath of a situation, making it clear to them that they are having a normal response to a messed up event, right? To something terrible happened, and that what they're experiencing in response to that terrible event is normal. It is expected, right? It's the human thing to experience after something like that occurs. And that can really go a long way toward preventing a lot of the characteristics that make PTSD become chronic, right? So if a person conceptualizes their response to the event as normal, they won't have the avoidance of stimuli related to it to the same extent that they will if they feel like their response to the event is pathological, right? They'll want to avoid anything that could possibly remind them of it or be remotely triggering, right? And that avoidance in and of itself sets the stage for the re-experiencing, for a lot of the negative downstream effects, right? The nightmares, that's from repressed cognitive material, right? That a person doesn't want to think about consciously. And so, lo and behold, they'll have nightmares about it. So if you're able to sufficiently normalize a person's responses to a traumatic event in the period immediately following, that goes a long way in preventing a lot of the nasty downstream characteristics of PTSD. So back to the social and emotional characteristics, being aware of how cultural trauma affects how people perceive safety and privacy, right? So just an example from my work in Native communities, any mention of a federal program does not go over well, right? There are a lot of sensitivities in Indian country to the involvement of the federal government in any of their affairs, and immediately will trigger concerns about safety and privacy in any of those community members. It doesn't matter that it's the National Institutes of Health who gave you a research grant to try and help with a problem that their community leaders actually identified in partnership with you and wants to help address in the community. Mention of federal funding is going to send people scurrying into the woodwork. So that's just one example. There are plenty of others. Got it. Sorry, I was just checking the chat. So in most of our environments, we need to do assessments of one form or another. And the kind of setting that you're in should guide your screening practices. Upfront, universal screening may be more effective in, say, a primary care setting. Whereas if you're in a behavioral health or a legal setting, you may want to do screening a bit later in the process, just for the sake of specificity, right? Any screening that a person is subject to should be for their benefit, not simply for data collection for your organization, right? The people who are conducting the assessments for trauma must ensure that once any risks are reported, they can offer appropriate options and referral resources. Those of us who conduct research, we have oversight committees called institutional review boards. And what they do is basically ensure that researchers are minimizing risks to participants and providing referral resources for any problems that are detected. Basically, doing this bit right here. So, for instance, if you have in your assessment battery questions about suicidality, you are required to have resources to provide a person with, or a plan to enact with a person who reports being suicidal. So that's just one example of how the screening should benefit the person, and resources should be at the ready for any issues that are discovered. In conducting your assessments, you should avoid rehashing the traumatic events that you may be assessing the person about. Frequently reassessing patients may increase the potential for re-traumatization because it requires them to revisit their traumatic experiences over and over again, right? And so whenever you require that, you have the potential for re-traumatizing the individual. Ideally, you would minimize the frequency of assessments and then share the results of the minimized number of assessments that are conducted across treatment settings with appropriate privacy protections. That's a practice that can be adopted so that the person doesn't have to retell their story to every member of the care team that they encounter. In the rehabilitation medicine setting, we would have team meetings where you would have the physician, the nursing staff, the occupational therapist, speech therapist, psychologist, and physical therapist get together and brief each individual's case minimum once a week, usually twice a week. And in those team meetings, it would often be my role as the psychologist to have gotten the person's story, and then sharing whatever that person shared with me with the rest of the care team, so that they didn't need to ask, right? So that they would know the person's story, know what things might be triggering for them. We would plan it all out to try and best support their recovery and healing. And that's a standard practice that can be very helpful. You wouldn't really want to allow someone to do trauma assessments until they've had sufficient training to do so. While all healthcare professionals should be proficient in trauma assessment, definitely, and conducting appropriate follow-up discussions with people that are sensitive to cultural and ethnic characteristics or the traumatic history. This was specifically for work in Indian country. Non-native as well as native staff can benefit from training in post-traumatic growth approaches. This is another sort of standard practice that can be helpful in settings that deal with individuals with a history of trauma, which is basically everybody. The notion that post-traumatic growth is an option, and the preferable option, is one that is gaining some ground in the field, and I hope will become a bit more widespread. But it's definitely worth having conversations about, seeking staff training about, and certainly encouraging in the narrative for folks that have recently undergone trauma. As a group facilitator for peer support, how do I minimize the number of times a group member has to share their story when it's typically necessary for other peers to offer support to know this background? For that one, I'm going to say in a peer support environment, you get much more one-on-one sort of personal relationships that develop, much more like a traditional friendship that's just in a very supporting manner and with, I guess, with an agenda to help the person heal. And so I think that the extent to which a person shares their story or how much detail about their story they share would basically be on a case-by-case basis for them and with each individual that they interact with. It's always a question of what the individual is comfortable sharing and with whom, right? And also in peer support networks, it can be a little bit less clear how much one should share about someone else's story with other peers. In the context of like a rehabilitation medicine care team, it's a little clearer how the information sharing should go. But when you're talking about more of a peer support network, because those relationships are a bit more like traditional social relationships, like friendships, it blurs into normal social interactions a bit more than it does in a care team kind of setting, if that helps. Do we have something else that came in? No, okay. In the chat. Oh, okay. So, summary. Trauma in one form or another is a major factor in community interactions. Our trauma response systems need to be sensitive in very concrete ways to the experience of our clients. So now I'd like to shift into the brainstorming scenario I mentioned a bit earlier. First, take a look just to see what came up through the chat. I think that's also important in peer group environment, is that there is no timeline to healing recovery. It's important to impress upon group members that nobody just gets over it. Yeah, I would agree with that. That's a really good point. Okay. So I'm going to provide a fact set, and then we'll explore trauma-informed responses of the various people in the system encountered by our main character. I did write this fact set specifically for a Violence Against Women Act and Indian Child Welfare Act training conference from last year. And so it is pretty focused on Native communities and some of the events that occur there, unfortunately. So just be aware that it is somewhat tailored toward that population. Okay, so Amelia is a 14-year-old girl who lives in Eagle Butte, South Dakota, on the Cheyenne River Sioux Reservation. She is normally reserved and quiet. She's an average student. She's well liked by her peers and teachers. Over the last month, her personal appearance has become less well kempt. She's had increased absences from school and has all but stopped turning in assignments. Today, during a class discussion about the slave trade and social studies, she suddenly began crying and excused herself from the classroom quickly. Her teacher instructs the class to go to the appropriate section in their textbooks, then discovers Amelia in the restroom crying in front of a mirror. Amelia displays all the features of an indigenous teen girl whose single mother has relapsed in her polysubstance addiction and has become increasingly absent in the last month. When her mother is around, she appears intoxicated and is incapable of parenting and shows signs of engaging in prostitution. Last week, her mother disappeared and hasn't returned, and Amelia is afraid that she's gone to a man camp and doesn't have any other supports available to her. So, the teacher. What are your thoughts on what the teacher should do, should not do, and how to proceed from this place? You can, if you're one of the panelists, you can just unmute yourself and share in the discussions. This is intended to be an interactive portion. What are folks' thoughts? Let's do the easy side of the question. What should the teacher not do? Chat. Jump to conclusions. All mandate child abuse reports. Let's see. We're not privy to our client's trauma history for that matter. Okay. 2 new messages. Ask the youth what's wrong with you. that would be a bad thing to do. Pass judgment or provide unwanted advice. Good. No, be judgmental, be open, just listen. Teacher should express empathy instead of punishment for disruption. That's good. Yep, that's good. Other thoughts? Create a safe place for her, right? Acknowledge feelings, ask what student needs. Teacher should not call the mom and berate her in front of the student. Very good. Don't vilify the mom to the student or in front of the student, right? Good. Should not say she'll get over it. That's absolutely true. Should not do that. Teacher, not make a big deal of leaving, being able to support the kiddo. Don't assume she is unsafe at home. Okay. Refer to a counselor. Okay. One thing that I haven't seen in the chat in terms of people's responses, leave out personal opinion. Yes, that's good. I haven't seen anyone say that the teacher should not try to get a detailed account of what's going on. And the teacher probably should not try to get a detailed account of what's going on. I like the refer to a counselor, right? So this child's obviously, clearly, emotionally having a rough time. there is a person within the organization whose job it is to help kids who are having an emotionally rough time. And the child should be referred to or offered the opportunity to speak with that individual, right? In a really non-judgmental and ideally helpful way. You know, it seems like, you know, you're having a little bit of a rough time. Would you like to talk to name school counselor here about that? And ideally, the school counselor, being a trauma-informed person, will have already tried to make themselves known to the student body, and so that everybody knows who they are, and worded in a way that does not sound like the teacher is passing the buck, right? No, it's that there's somebody whose specialty this kind of thing is, who has the specific training for helping out in situations where kids are having a rough time. Yeah, Carlos.
But what about when the resources are not there? You know, I mean, an example, I know that some people don't think that kids who are 4-year-olds or 5-year-old have trauma, but they do.
Oh, yeah.
So an example I give you in the Head Start community, the kids, I did research on trauma and mental illness within children. And when I spoke to the directors, there was no way of them being able to provide the services that these kids needed, because there were so many of them that were traumatized. And so what are you going to do? It's going to be like, it's impossible, you know, to actually help them so they move on from Head Start to kindergarten forward to first grade and never get the services that they need. So my question is, are these kids that are never taken care of when they're children, do they become people who traumatize other people?
Right.
As they get?
Yeah. You know, it's unfortunate that the resources aren't present in the programs where they could be delivered most effectively. You know, and early on is best, right? I mean, you don't want to let trauma fester, because it just starts manifesting in all kinds of other problematic behaviors as the person develops. It gets worked into their character and into their personality. And so addressing it earliest is certainly best. But unfortunately, like you say, the resources aren't always present. And that's just an unfortunate fact of our social safety net system, right? It's just not very well developed in this country. Sorry, I didn't realize folks might not know what a main camp is. It's the oil fields in that area of the country are staffed largely by men who go there from other communities, and they work the oil fields, and they're organized into a camp. And a lot of really unfortunate things happen when you get a lot of men with relatively lower levels of education and income together. It's just, yeah, it's unfortunate. So I want to go back to one of the questions that was in the chat, trying to get it to scroll up. So this can be answered later, but I'm curious about trauma-informed responses that may differ based on the teacher, counselor, police officers' racial, ethnic, indigenous identities. Does this ever come up? Absolutely, it comes up. I mean, totally. You can't divorce yourself from your own identity, racial, ethnic, or otherwise. The thing that when I gave the de-escalation training last week, there's an acronym that I conferred to folks, QTIP, quit taking it personally. And that basically refers to the mindset that you need to have as a helping professional. You need to understand that what behaviors are being exhibited by this person are due to their history, their context. It's not about you. Now, that said, you can't use a racial slur against a person of a minority group or any other group for that matter without eliciting some kind of a response. And that's going to largely be up to the police officer, counselor, teacher, whoever it's directed toward, how they personally are able to respond in that moment, given their own emotional resources, cognitive capacity at the time, so on and so forth. But certainly it comes into play, and you can't really divorce it from the situation. You just hope that those things aren't used in a hurtful manner, if at all possible. Sure. Then there's something in the Q&A. My org, I'm not privy to clients' history or trauma. How can I effectively help them without these? So since you don't have access to the client's history, largely just ask them what their preferences for things are, right? So whatever, I don't know what your role is, but I'm assuming you're not that jerk in billing who's always mean to people, because they wouldn't necessarily have access to the person's history either. But largely just letting the client define the terms of their engagement with you in whatever ways that they feel most comfortable doing. Just how can I help you today? And let them tell you, right? I don't, like I said, I don't know what your department is, but I'm assuming that question, how can I help you today, would probably be an appropriate one to start off with. So I did put these different roles in with the fact set for a reason. What would folks say that reason might be? So the teacher has a very specific role. The counselor has a very specific role. The police officer that the counselor is going to have to refer the child to has a very specific role. How can each one of these people do their job in the system in a way that doesn't further traumatize the child? Order of contact, different levels of power to elicit the different responses. Right, each one of these people exists for a specific function, right? The teacher is there to educate the children and maybe to detect any first line problems, open communications among systems. You'd think so, but not necessarily. The importance here is that the information does not necessarily need to flow backwards in the system. The police officer doesn't need to report to the counselor, doesn't need to report to the teacher, right? The teacher needs to report their observations to the counselor. The counselor needs to do their job and report the relevant portions of what they discover to the police officer, right? Right, you have to have a release of information. But only the relevant information should be transmitted to the next level of care in this system, right? So the counselor, if they find out information that's not relevant to the legal aspects of what the police officer needs to be made aware of so that they know how to do their job, they should not share all of that information. They should only share that this child has been without a parent for the last week. That's really the only information that the counselor needs to share with the police officer. The police officer will then conduct their own investigation of that aspect of things, right? Exactly. Everyone has their own position of support and does something the others may not do. But the key bit that I wanted folks to grasp here is the direction of information flow and the kind of information in a trauma-informed way should be shared and should not be shared. Because that police officer having information about the child's drug use herself, which I didn't include in the fact set, but say there was some, is that necessary for the police officer to do their job in terms of investigating potential neglect? Not really. That is something the counselor can work with the child about and help them to ideally access, treatment for that aspect of what's going on in their personal life. But that's not something that they need to inform the police officer about, right? So in a trauma-informed system of care, there are still silos. It's not just that everybody is sharing all the information about everything with everybody else in the system of care, right? There are specific functions and specific amounts of information that those functions need in order to serve their function. Does that make sense to folks? I'm hoping so. Okay. Then moving on to further up in the legal system here. When you get to the attorney that the child is eventually going to be assigned to represent them, because a child obviously cannot represent herself in a court, and she's going to have to enter the legal system and interface with lawyers and judges and people like this. What are the kinds of things the attorney should be focused on in a trauma-informed system? And what kinds of things should they not be doing? Things that would be perfectly within the role of a lawyer, but not necessarily if they were trying to be trauma-informed. Looking for chats. That she is safe. Okay. The attorney's job is to make sure the child is kept safe. Sure. They also need to, negotiate the system for. He should be careful of her mental health stability. Sure. How does that look? Facts of the current situation, asking about certain details or more details. I hope you're saying not asking about certain details or more details. So one of the things that the attorney shouldn't do, and I think this is where the respondent was getting to, is a complete reassessment of the entire situation from the perspective of the counselor, right? Now, the attorney may meet with the counselor to get a fuller context for the child's care needs, because they're going to have to navigate the system for the child and make sure that those needs are provided for in whatever setting that she's going to next. But they shouldn't try to get that story from the child. This is one of those cases where the information does actually need to flow, from the counselor with greater sense of context. Information the police officer didn't need to know, but the attorney may, right? And then the attorney can then inform the judge, who will ultimately make the decision about where the kid goes to. The attorney should not ask the child for the details of the situation. Instead, the attorney, in a trauma-informed way, would avoid rehashing the situation with the child and would rather get that information from the counselor, if possible. This is one of those cases where if you can avoid a reassessment, you should, right? If somebody else has already assessed in depth and in their function, that's what they're supposed to do, right? Then the attorney should get that information from that most appropriately trained individual who got that information directly from the child. not from the child themselves. So, hope that makes sense. And again, this is just letting everybody do the role that they are specifically trained for, right? The attorney went to law school. They didn't go to a counseling psychology program or a social work program, right? So they have an area of expertise that they can bring to bear on the situation for the well-being of the child, for Amelia, right? They have a role that they have specifically been trained for, and they can do that role in a more or less trauma-informed way. Similarly, the police officer in the last slide shouldn't try and get a detailed chain of events from the kid so much as just assessing the risks that she's facing in her current situation, right? The cop doesn't need to know the extended dance mix history in order to serve the police officer's function in this system of care. How about the judge? What should the judge do or not do? Criminalize the child. Very good, Carlos. Thank you. Yeah, to the extent possible, the judge's role should be to create as few victims in the scenario and to get the information from the attorney, not the child. Right. Exactly. This is all about information flow, right? To be trauma informed is to manage the information flow. Right. The judge should not ask the child. That's right. Nobody who wasn't specifically trained to do a psychosocial assessment should be conducting a psychosocial assessment, right? So this is part of being trauma informed, is letting the people who have the specific training do the specific job. And so the judge should get their information from the attorney who got it from the counselor and take all of that context into account in making an adjudication for the child. And Penny says, do not make the child feel like her mother is a criminal. Right. The judge's job is not to vilify the mother. The judge's job is to see to it that the child is cared for. Right. The attorney is also trying to see to it that the child is cared for. Nobody's prosecuting the mom in any of these steps. Right. The police officer didn't go and try and search and find the mom to arrest her. Right. That may happen, but not if it's a trauma-informed system, right? That shouldn't happen in a trauma-informed system. The focus should be on the individual in need of assistance, right? So at no point along the way should any of these people be vilifying Amelia's mom. If anything, they should be possibly trying to provide resources, but if the mom is not readily available, they wouldn't go hunt her down, right? They would just work with Amelia to make sure that her needs are getting met. Judge will always follow the law and hardly deviate from it, which makes for an emotionless process for the child. That doesn't have to be the case, Carlos. It doesn't have to be. Good buddy of mine, Ron Whitener, was the Tulalip tribal judge for a number of years. And, he would call me up occasionally and ask me my opinion on something. And as a psychologist, I would tell him, what likely would be the best case scenario for that individual in that situation. And as a tribal judge, he had a fair amount of latitude in what he could mandate or choose not to mandate, or what he could, just recommend versus mandate, right? So there's a fair amount of leeway actually for judges in these cases. Now, the thing that the judge can't do is not make some adjudication for the child such that she's placed in some kind of setting that will provide care and supervision, right? That he's got to see to the well-being of the child. But it doesn't have to be an emotionless process. And certainly without doing a reassessment and rehashing, the judge can have a conversation with the child about her preferences, and what she would, which of the available options she would like going forward, given that her mom's not currently able to provide, parenting for her. What of the available, so there are group homes, there are foster placements, there are, a range of potential places that this kid could go. And that's where the role of the case manager is now going to come in. What does the case manager need to do? We have to look at why the mom is MIA. Do we though?
What happens is we only tend to look at the child and what the consequences are for the child. So basically, either we take them away and we put them in a system that for a Latino is not a good system.
Yeah.
Okay.
It's not for Indians really either.
Right. It's not a friendly, and that traumatizes the child more. So I think that this system that has been created has to change so that we can start looking at what is really happening to the family nucleus. Why is this mom, and try to find a way to help the mom so that at the same time, by helping the mom, we help the child. But that's forgotten because I've seen it many times where they just take the child away. Nothing is done with the mom. The kid is traumatized. I see many times where moms come crying to me, telling me, I want to see my kids. I change. I haven't done what I was doing before.
Mm-hmm.
But still, there's no opportunity. They have to go through the course system and all these other stuff. Something has to change within that system so that we could start seeing why it is that the child is going through what he's going through.
Yeah.
Because if you don't stop it, it's just going to be a cycle.
Yeah, there's a few things that I'd like to respond to in what you just shared, Carlos, which is what happens right now. But some of the things, I'll just pick the first one. So the mom having to go through all these hoops in order to get contact with her kids, I agree with you entirely. That's not helpful, right? Especially if she was able to clean herself up enough to come to the system and engage with the system, in a sane manner, then that indicates some level of restored judgment and probably should warrant access to the kid in some form, whether it's supervised or not, right? My wife, she's a harm reductionist. So she works with people who are not ready or able to stop using whatever substances they're using. And one of the things that she preaches that I agree with is that you can't insist that a person be fully healed before they can access services, right? That's just not a helpful approach because people need the services to get fully healed. So for instance, housing is a big one for her. She's a big proponent of housing first. That you can't require that someone be straight and sober to provide them with housing. That's backwards, right? You see that once you provide somebody with housing, they stop using so much and they start doing other things to take care of themselves and they stabilize. So I totally agree with that statement. Now, the point that I wanted to focus on with regard to finding out why the mom is MIA, you need to find that out from the mom when she presents to the system, not from the kid, right? Then this is one of the characteristics of being a trauma-informed system of care, is where you source your information, right? And the kid won't have the complete picture of why the mom is MIA anyway. And there's no need to ask her a bunch of questions about that if you're doing a trauma-informed approach, right? You want to minimize the trauma that this child experiences through this process. And having to answer a bunch of questions about her mom and her mom's history probably is not the best way to go about that. But when the mom presents to the system to get access to the kid, then you start your assessment of the mom and her situation, right? From a trauma-informed perspective, that's the order of operations that you would want to occur. Yeah, it's unfortunate that people don't understand harm reduction yet. It really is. It's very unfortunate. But you're right. It's absolutely key for most of the populations that most of us work with. Yeah. Okay, so then the case manager. What is their role? What have they specifically been prepared to do? And how should they do and not do it? What are some things the case manager should not do? That's an easy one. They should help find services. Yes, absolutely. And they would need to be able to determine what services are appropriate and needed for this kid in this situation, right? Now, what they should not do is the kid and the mom. Ideally, when the mom presents to the system, no false hope to the child about her mother. True. Also, no vilifying the mother to the child. Focusing on the kid's needs and getting a full picture of what needs this kid has in this situation and what resources are and are not available. Should not threaten the mom with punishment. That would not be helpful, especially not to the kid, right? Oh, your mom's going to be in a lot of trouble when she shows up. No, there's no need to talk like that, right? That's not helpful. It should all be focused on Anyla and what her needs are at that time. And then the case manager, everybody's got their expertise. The case manager knows what services are available, what resources can be mobilized, what help can be marshaled for this kid, and the extent of find a person she feels safe with. Case managers are not counselors and should not interview or reassess child parent in a clinical way that exceeds the skill or accepted protocols. Yes, exactly. Right. They need to assess what the kid's needs are, not the full clinical picture, right? They're not, a case manager is not a counselor, right? Just links the client to the services and letting the child express her feelings and preferences. Yes, Penny. Yeah. If the kid doesn't want to go see a counselor, she should not be forced to go see a counselor, right? She should be offered services, not forced to engage them. Now, the exception there is where it comes to her safety. She's got to be placed in a safe environment. So, she should present the options to the child. These are the safe environments that are available. If there's a family friend that she feels comfortable with who's willing to do it, fantastic, if that's a safe environment. The case manager's job is also, though, then to assess that environment and determine whether it is a safe environment, right? Again, everybody's got their lane. Engaging all members of the case, providing visitation for those in placement. Case management encompasses so much. It really does. Yeah, no, it encompasses a lot. Love, empathy, and compassion with a sound mind, understanding of the child needs. Yeah, indeed. Okay. Coordinate care, advocate, and link to supports. Yep. Very good. Okay, cool. Well, I think that y'all have got the gist of what a trauma-informed system of care should look and feel like. Would you say that's accurate? Okay, cool. Go ahead and open the floor for general discussion. After some closing thoughts, trauma-informed systems of care need to recognize what might trigger trauma responses and avoid those characteristics, be they physical, social, emotional, or systemic. This is relevant at every level of the system of care and in every single interaction. Someone doesn't feel safe, they can't fully heal. So there. Everybody gets to learn a word in Cherokee. Waton. Thank you. Open floor. Thoughts, comments, questions? Feel free to unmute yourself if you have that capability.
Thank you, Lonnie. Sorry, I had to duck out for just a few, but notice there are still a couple questions. I want to make sure that you may or may not have already answered those. And if so, those are all taken care of, it sounds like, perhaps, in the Q&A.
Yeah.
Okay, perfect.
We just
All
can't
right.
close them because somebody's typing an answer for both of them.
Oh, I can close them. Okay, I just wanted to make sure that we didn't. Okay, I'll leave other people to unmute or ask some questions.
Hello.
Hello.
Hey, how are you, sir?
All right. How you doing, Lamar?
I'm doing pretty well. I wanted to thank you for this information. I just started working with the Mississippi Band of Choctaw Indians in Philadelphia, Mississippi. And I wondered how much cultural humility plays into this trauma-informed approach. You mentioned something earlier about federal, and I want to parallel that with another question or just get your insight on the mention of federal anything can be off-putting.
Yeah.
And what I've found, and this is new to me, they just kind of recently let me in, so I'm excited about that. But I also wanted to ask, how would you need the funding, right, to support the work. But I understand with, the tribe being sovereign and very much, like you said, opposed to a lot of outside interference, or not outside interference, outside support, or very skeptical of it. How would you approach, hey, look, we need this funding to support the work. It may come from a source that may cause us to re-experience, some uncomfortable feelings and thoughts. Like, how would you kind of broach that?
Yeah, I do have some thoughts on that.
Thank you.
Because I do access a lot of federal funding sources to fund my research. And I work in Indian country all across the country. And what I do is I focus the information and the conversation on the community-based participatory research process, right? That it's going to be community guided. That I don't focus on the fact that it's going to come from the National Institutes of Health. So you don't need to focus so much on the source of the funding as on the process of how those funds are going to be put to use and where the direction for how those funds are going to be put to use is coming from. And ideally, it should be from the community leaders, right? That's where the direction of how the funds get used should be coming from. And that's one of the reasons I always engage the community in the process of writing the grant application, right? I get their guidance as I'm putting together the application, and so that they have full transparency on what I'm doing and how I'm asking for the funds and for what purpose. And it's only going to be for the purpose that they told me they want funds to serve, right? So that's how I approach the topic, is by focusing the conversation on how the funds are getting used and where the guidance for those uses is coming from. And ideally, if you're doing your job right, Lamar, that guidance is going to be coming from the community. Cool. Got one in the Q&A here. Suggestions for minimizing a loud and crowded waiting room. Our facility is also a drop-in for resources and food, so a lot of people come all day long. It gets very crowded and loud, which is uncomfortable and triggering for folks. Yes. So I'm also on the board of directors of the Chief Seattle Club. And this is an issue for the Day Center at the Chief Seattle Club as well. And one of the things that I advised them to do, which I think that they've been able to do with varying degrees of success, is to, first of all, try and develop good basic relationships with all new members who come in, so that they've had a conversation with at least one of the front desk staff and have a rapport. Now, there's an advantage to the fact that they have members, right? So there's a process for becoming a member. And so as part of that process, they can develop that rapport. And that's one of the ways that can be helpful in intervening in this kind of situation that you're talking about here, where you've got a crowded waiting room and you've got people being loud and so on and so forth, because you have an existing relationship that you can access to try and encourage folks to be respectful of the others around them, and use their inside voices and so on and so forth. But that's, I guess, just like in the de-escalation training, my first advice is, an ounce of prevention is worth a pound of cure. So if you can have that good initial rapport with people that are coming in the door to the best of your ability, then you can more easily influence their behavior, and they're more likely to be receptive if you ask them to lower their voice and calm down a little bit. Just make it a calmer environment for everybody. So I guess that's my first answer, is that an ounce of prevention is worth a pound of cure. And having the expectation, and there can be friendly signage around, reminding folks to be respectful of others, and keep their volume to a reasonable level, and so on. Other questions, comments, thoughts, observations? Yeah.
Hello.
Yeah.
Hey, I'm sorry, I have another question.
Not at all.
I know you mentioned you gave a lot of information on like specific interventions that people can use. I wonder, how does that look in a broader context of community-based mental health clinic, or just an agency where there may not be complete buy-in from everyone to approach people we serve as from a trauma-informed lens. I've been in settings where one person might, if I'm gonna just give a generic example, but like one person might use recovery language with the people that they work with, and somebody else may use stigmatizing language with people that they work with. So it's not agency-wide buy-in per se on a day-to-day basis, maybe in language or whatever. But how would you navigate that, maybe from a systemic level, how to continue to advocate for that approach?
Yeah, this is about providing training to staff, and making sure that they get consistent ongoing supervision that's consistent with that training. Not everybody comes out of their program or out of their career. I mean, if they've been in the mental health field for 20 plus years, then maybe they were trained with stigmatizing language, right? I mean, not everybody comes out of their educational experience with a trauma-informed lens. At least they didn't used to. I don't know if they're teaching that in all the graduate programs now. I hope they are. But yeah, it's a matter of training and consistent supervision that reinforces that training.
Speaking of, I'm actually
You muted yourself again, Christina. I think you mean to be heard.
Sorry. It was brilliant, whatever I said. No, sorry. Too many things going on my screen. Sorry, we do have an event. We've worked with another wonderful presenter, Rebecca Demerol, who talks a lot about trauma and resilience and that sort of thing. So she did a webinar last Friday. She'll be doing one, and I can share my screen, but we're doing something on this Friday called Trauma Informed Supervision and Resilience. So I'll have our team put the link to register in the chat. There it is.
Perfect.
Yeah, I mean, it's a big thing that we like to talk about and make sure that, our well-being as providers and that supervision, all of that is really important. So thank you for bringing that up. But
Yeah, Christina, was Lamar a plant for that?
No, but you know what? You do this long enough, and I know you know this, but when people attend these things, a lot of similar issues come up. I wish all of these were all fixed by now, but we have, always growing to do. So we just keep offering these kind of topics. So thank you, Lamar, for doing that. Other questions? We still have Lonnie here as long as we can for another 12 minutes or so, but anyone on camera wants to ask a question or make a comment?
I want to make a statement real quick. I think that the systems that are in place right now have to become more culturally sensitive. An example is I have seen where therapists, counselors, case managers are dealing with somebody who has trauma, but the language that they use either triggers the traumas on these individuals or it's offensive. So unless we start understanding our cultural differences, I don't think that it's going to be 100. Not that I'm saying that it's 100% effective, but it's not going to be as effective as it should be.
Yeah.
As a Puerto Rican, I have spoken to people to deal with traumatized individuals, and they have told me, share with me, of course, anonymously, not giving me the person's information. And they have told me I said something and the person triggered. It triggers something because the person got aggressive with me. What did I say? And I think we have to start putting that into place so that we could actually be inclusive of everybody's needs. Because, and I'm going to be very blunt about this, what a Caucasian feels and believes is not the same beliefs that I have as a Puerto Rican. So that could create a conflict between me and the person that is trying to help me, even though the person is there with empathy, compassion, and love to try to help me. But unless we start, what's the word I want, putting it in, it's not just saying it, because I'm hearing a lot within the system. Oh, we have to start changing the system, but it's just in words. It has to really be put in there in the training, in the teaching, and that's not happening. So I'm hoping that maybe as we start going forward, that we start thinking about that. Maybe we'll see a better relationship between a therapist and the traumatized individual. Between the police, I am totally against inviting police officers into any trauma unless there is a chance that this person might hurt himself or hurt others. That's not acceptable. So, a little controversial. He told me sometimes, oh, Carlos, and I got friends who are officers, and because I experienced that with my son, and I don't want, if it wasn't because my son, I have a friend who's a police officer, my son would have been killed. I know my son would have been dead because the officers that they came not as guardians, but as warriors. I have to deal with somebody who is being aggressive. So I'm going to have to take them over and slam them and put cuffs on them. And, you know, and my friend being a police officer and a compassionate individual was able to deal with my son in a way that I was like shocked because I couldn't even deal with him that way. You know, I was ready to, I think I'm going to have to, use force, not somebody else, use force to make him do what he needs to do. And so this is stuff that we have to look at, you know, because I don't want another Daniel Prue. That's the person that was killed in Rochester, New York, where I'm from. And I don't want another George Floyd, you know. Right. And so when this happened, a lot of the people started talking about trauma and how we got to be culturally sensitive. But you know what? After 2.5 years, almost 3 years, we're back to the same routine. And we don't want that to happen. We don't want to forget. We have to make sure, because I don't want to see that ever happen in my community. I saw it in other people's community, but when I saw it in mine, it was really like heartbroken. I mean, you know, seeing the family, you know, knowing what they were going through, how the community reacted. So please, we have to get to instill, I don't know the word. My English is not great.
I think you're conveying your meaning very well. I think that you're conveying your meaning very well.
So that's what I want. I just want to bring that up. You know, I don't know how people feel in here, but
yeah. And last week, you know, I gave one of these webinars on de-escalation from a trauma-informed perspective, and it was pretty well received. I think there should be a recording of that training available at some point, right, Christina?
Yes, our team will put that in the chat. And, you know, I mean, you're 100% right, Carlos. I mean,
yeah.
I have to work hard. It is up to me as a white person to really try to be as informed as I can about how these different systems and interactions and factors that come into play, you know, because if I just see it through my lens, it's not going to be the same. And, you know, I wish it didn't feel like it's sort of just words. We were just at a conference a couple of weeks ago, the State Washington Behavioral Healthcare Conference, and one of the sessions we did with one of our presenters is, you know, hidden in plain sight. You know, how bias and racism and all that. So it's still very alive and well. It's still deadly, and we have to figure out a way to convey that in these training spheres as well. It's, you know, but it's people level work, and it's, you know, it's not done in one day. And, you know, I think about what you said, you know, oh, it's something that sets somebody off. You know, we're going to make mistakes. We're going to not always have all the information. And I think it's our spirit of coming to these interactions, of being humble and being curious and being kind and being open. And, you know, and then I think of all the stuff that, you know, Lonnie, you started with all the traumas of just doing the work, helping other people, you know, and talk about controversial, you know, I mean, I think police are traumatized. They also need more training too, you know, and so it's like this whole circle. I mean, you sort of said it last time, I think very well, Lonnie, about most all crisis or escalation is stemming from trauma. And I think that comes from all the aspects of these interactions. And we, you know, it's up to us to figure out what are those things that we've gone through to know and have ways to deal with that. But, you know, it's an ongoing, lifelong journey. So I think hopefully someone will get in the link to our recording from last week. So that was really an excellent talk as well. Thank you, Carlos, for sharing.
Oh, there it is.
Yeah, there it is. Thank you.
Yeah. I think, Carlos, that you'll enjoy watching that training, because a lot of what you were just saying was in that talk. So, yeah.
You know, we comfort the afflicted, but sometimes we must afflict the comfortable.
Yeah, there's some norms, and that's what we talked about. And this is not my information, but these, you know, you've heard of these norms for courageous conversations. That's what it makes me think of that you're talking about. And Carlos, you're You're trending. No, I'm just kidding. Someone's asking for your information, which I'd also appreciate. I guess we have everybody's information because you registered, but I'll just say, I love the kind of stuff that people are talking about. These are not easy things to discuss. And it is very nice. We haven't normally done this on a webinar, especially of this size, to be able to have these conversations. And I always want anybody here, Lamar, Carlos, you're just who I was able to hear today, but y'all have wisdom we can share too. And we pay you to come and do exactly this. So please be in touch with us. Oh, look at those eyes. Okay. Yeah. But, I feel it's imperative. I sit where I sit, and what I can offer is the power and the platform of what we have to share the wisdom that y'all already have, Lonnie being one of them. And, but you all are there as well. So please get in touch with us if you'd like to present or talk about presenting or doing something where we can have a little more time. That is something that I strive to do. And there's nothing wrong with all the other amazing work that's out there. And people with PhDs can be nice too, right, Lonnie? So nothing against our doctoral level people, but I think all y'all doing the work is also a place where we need to have your voice.
I just want to give a shout out to the MHTCC crew. They are fantastic to work with. They make it painless to do these things. And they provide a platform for, this kind of interaction and this kind of information sharing that's free to anybody who wants to sign up and listen. So, yeah.
Thanks. I put my email in the chat. Please email me directly. I'm none of the co-directors, but this is what I live and breathe for, honestly, in my work. And I can't stop trying to get more content like this because it feels like my mission in this center. So I would love any and all of you that would like to. I see Roxanne raised her hand. I know we're about 30 seconds out from being done. Roxanne, I don't know if we can unmute you. Nope. Lowered the hand. Could just be an accident. Well, I know we're out of time and I don't want this to end. And I kind of, like many people, wish we'd just do this every week, but we are out of time. I want to thank you, Lonnie, so much for your time. I want to thank everybody who was patient with us trying to do this panelist sharing discussion thing, which we haven't really done. Last week, we failed miserably. So this week, if you were there, just was new to us and we had just all been gone for a week. So thank you everybody for sharing or for being here and your questions. And we'll see you next time. Any parting words, Lonnie? I guess you already said thank you and goodbye, but.
Yeah, no, just thanks everybody for your attention and for all the good work that you do every day. I hope that I said something that you found useful and helpful along the way. And Carlos, Lamar, thank you for engaging, for talking with us.